Hello, I'm Matthew Weinstock, Managing Editor of Modern Healthcare. Thanks for tuning in to the latest edition of The Checkup. Over the past few weeks, Wisconsin has turned into one of the nation's hotspots for COVID-19 cases. Joining me today is Dr. Susan Turney. She's CEO of Marshfield Clinic Health System in the upper part of the state to talk about the impact the pandemic is having on rural communities, including the role that hospital-at-home programs can play in caring for patients. So, Susan, thanks so much for being with us. We know it's a very busy time for you up in Wisconsin.
Thank you.
And I'm always happy to welcome a former fellow Badger to the checkup as well.
Thanks for that as well.
So let's talk about what you're seeing in the state. Wisconsin has definitely become the hotspot across the country. You're seeing spikes all across the state. I know you're seeing some increased utilization at Marshfield, but maybe not ready to open up a full COVID unit yet. Talk to us a little bit about what's happening.
Things have changed a lot over the last month for us, clearly. The impact, I'm sure, is the same for nearly every healthcare provider in the country right now, and it has been profound. And as you mentioned, Matt, we are really seeing a spike in the number of cases in Wisconsin right now, which is very unfortunate. But even before the virus was widespread here, the impact of this pandemic has really been very immense on our healthcare system. Even though early on we were relatively unaffected by the actual sickness of the pandemic, but in order to flatten the curve and to protect our workers and our patients, we shut down almost all of our non-urgent care. And in fact, in the first month, which seems like eons ago, it was only 7 months ago, we lost nearly $70 million. So this has had a huge impact on our local businesses, our local industries, and our communities as they had to shut down to curtail their normal operations. But, even in the absence, I want to point this out, of a major outbreak, our communities were socially and they have been economically devastated. And now with a spike in Wisconsin, there are a lot of things that we need to take into consideration. Certainly, we need to make sure we have enough hospital beds available. We need to ensure that we have enough PPE and enough testing capacity. Like others, we've changed most of our operations. Pharmacy operations, our patients are receiving their medications through mailing. They're not coming in to receive that service. We have done everything we can to really reduce that in-person contact and that potential exposure. And with that, like others, we've ramped up telehealth. It's interesting because we've been doing telehealth for over 25 years, and adoption rates have been not extremely high prior to the pandemic, and in part as payer policies have not really kept pace with the changing delivery of healthcare. So just in the first couple of months of using telehealth, as we tried to minimize contact for our patients and for our providers, we did 4 times the number of visits than we had completed all of the previous year. And we still have about a quarter of our workforce working remotely. So there are a lot of challenges, and I see the challenges worsening over the next 3 weeks as the number of inpatients that we've had over the last 3 weeks have increased 3 to 4-fold.
There are a couple of things I want to touch on there, but certainly on the telehealth piece, obviously rural communities have been disadvantaged because of broadband access. Has that been a problem for your communities, and how have you been able to overcome?
There is a challenge with broadband in many of our communities. And I have to say that working with communities, since we don't have a statewide plan right now, we have helped to support them through funding so that they do have access to broadband. But we still have 10 to 15% of our population that we serve that does not have broadband service. So so a lot of the virtual visits were telephonic rather than face-to-face on a virtual platform. But we were able to serve patients and continue to serve patients in this way. And I think one of the things that you pointed out is really important. Rural healthcare was already in deep distress before anyone had heard of COVID-19. So we want to really let people understand that rural healthcare, the pandemic is really a crisis on top of a crisis for us. There are about 50 million people who live in rural America, and these are what are called healthcare shortage areas. And we know that the number of physicians practicing in these areas, particularly in primary care, family physicians, surgeons, paramedics, have declined to an all-time low. So when we also add the complexity of the fact that rural Americans are older, sicker, and poorer than their urban counterparts, and in fact have an average household income of $8,000 less than the state average, they're suffering. They were suffering before the pandemic. So having telehealth was a huge opportunity for us to connect with our patients, and they love it. It's going to be really hard for anyone to turn back the dial on providing services virtually. But for us, where patients, not uncommonly have to drive 2 hours for a visit, it's a game changer for our patients, and they love the flexibility. They love that we have this resource, and to pivot any other direction, but continuing it in this way is going to be a real challenge.
Sure. I'd imagine that, everyone's gotten so used to it that it will be hard to switch back, especially, when we're used to it in so many other parts of our lives, the remote access to things. I want to get to the financial piece because, as you said, rural healthcare, rural hospitals have been struggling for a number of years. We know from data from University of North Carolina and others that there have been a lot of closures over the years. A lot are on that line of closing even now. So what can happen going forward? As you look to 2021, 2022, how can you begin to shore up your financial base, if that's even possible, as we come out, if and when we come out of this thing?
The if and when, right? That's the tough part of all of this. I think I've been CEO here for 6 years, and when I started at Marshfield Clinic Health System, we were ambulatory care and have been for over 100 years. In the last 6 years, we've acquired or built 10 hospitals. So we have prepared for our future by really creating a fully integrated health system with including a provider-based health plan, which has really given us a lot of opportunity to be creative and innovative in the way we deliver care. I know that Wisconsin has a lot of critical access hospitals. We have a very robust rural healthcare system, especially in the northern half of the state, which is very rural. Mm-hmm. And it's only been in the last year or so where hospitals in Wisconsin are at significant risk of closure. And at the same time, we're investing in hospitals in rural areas. And, our mission is to really serve patients and enrich their lives and meet their needs as close to home as we can. So it really is imperative that we have hospitals within our communities. Having said that, we also know that care delivery is changing dramatically, and with the use of telehealth, we have been able to offer different services like our hospital at home program, like home recovery care, that really has allowed us, with the health plan, to redesign the acute care delivery model. So I think we're positioning ourselves well. We're hoping payment methodologies catch up with these new delivery models, especially in rural areas, but certainly just in general. And if they don't, it will be more challenging for us. But I do have a lot of optimism that with the relaxing of the telehealth rules, is just one example, that we're on the path. We're on the right path.
Yeah, but we've also seen some insurers start to dial back payment for telehealth. There's also been reluctance both at the federal level and the insurance level and the private payer level for sort of hospital at home programs. So how do you start to encourage the payer community that might not be affiliated with a health system? How do you get them to start to embrace some of these changes?
Well, it's obviously challenging. I mean, when you think about the national payers and the commercial side, their one-off programs are hard for them to implement, obviously, to change their entire system for one type of operation in Wisconsin is a challenge. However, in the last 4 years, since we partnered with Contessa to offer hospital at home, our health plan was, first at the table. And because of our success, we are now getting the attention of other large payers. I also think if a site of service, if home is a site of service for payment for many of the services that would only be paid for as an inpatient or an ambulatory care, that also pushes us in the right direction. The thing that's so challenging is that we, as a health system, we have very different markets, even though we're very rural. Our market in Northwest Wisconsin is very different from Northeast Wisconsin, is very different from Central Wisconsin. And there isn't a one size fits all, even within our own health system. However, as we look at providing hospital at home as an example, with the use of telemetry, we've reduced costs for services by 17 to 30% compared to a typical hospital admission. And that's just part of it, because there's also a 55% reduction in readmission and a 30% reduction in the length of stay. So when you look at those numbers, it's hard to think that people wouldn't want to pay for services that are delivering high quality, high patient satisfaction, 98% satisfaction at a lower cost with the same or better outcome. So this model makes sense, and it makes sense particularly in rural areas, but I think it's important to offer this service anywhere in the country. It's just a huge victory. It's a huge victory for the quality of life for our patients, for our families. And right now for us, particularly because we started talking at the beginning about the pandemic, it frees up hospital beds and resources for the folks that do need to be in the hospital. And during this pandemic, the hospital at home program has really been a lifeline for us, allowing us to manage patients in the most optimal way we can.
And so, let's stick on that program a little bit. Just talk about, if you were talking to your peers in other rural communities, what are the things they need to do to think about setting up a program like this? What are just the baseline things they need to consider?
Right. Well, I think there are several things actually. And when we started the program, we ramped up very slowly. Now I think because we've had such great experience and can share what we've done, the ramp up can be much more quickly. When we started this program, we had already had a telehealth program, and we're already doing virtual visits. So that certainly is something that's absolutely necessary to have a hospital at home program. And I would guess that most practices across this country were able to implement telehealth because of the pandemic. So you need to have a system where the nurses are able to do in-home visits, and it has to be an acute care registered nurse. And you need to be able to provide the virtual visits with a physician. And we use our hospitalists in our program to provide the inpatient care at home. You also need to have a committed or a dedicated recovery care coordinator. And of course, that has to be available 24/7. And then obviously the remote monitoring of vitals, biometrics, and adherence to a care plan, medication use, et cetera. I think one of the things that is challenging is just a different way of providing care. And we started with 5 DRGs when we began our program, because obviously we wanted to make sure that what we thought would happen happened, which was lower cost of care, the same or better outcome, and high patient satisfaction. But it took some time for our physicians to really adapt to the program. However, after about 1.5 years of the program, we opened it up to all DRGs. And, after they do a home visit and set up what is necessary for the patient to be taken care of, which we do the same day of the admission, again, it's been a huge victory for us. There's just no question that, again, this is one of those things that I don't think we can dial back. Our patients love it. Our families love it. And again, going back to our rural roots, most of the people in our communities work in small businesses. Many of them do not have paid time off. And oftentimes the patients that we're taking care of are elderly. They're so the person who's working has oftentimes to figure out what to do with childcare.
Right.
So they can bring their parent for care. And then they're taking off work. They're not getting paid. They're traveling a couple of hours. And this way, it just makes it easier for our patients and our families. And I mean, we're just thrilled that our health plan was able to invest in this, because it's really been worth the change. I mean, it benefits everybody, the physicians, the other providers, the patients, the families, and our communities, because people are working.
And you see it growing beyond, into 2021, 22, 23.
It will grow. As we've added hospitals, of course, people say, well, why would you have a hospital at home program when you have a hospital? Well, for the reasons I've described. When I say that, however, as we built hospitals or acquired hospitals, we're still pushing hospital at home or home recovery care into our communities for the reasons that I've described. It works, and we aren't going to change that plan, and it does meet our mission.
Got it. Well, Susan, we appreciate you taking time today. Again, like I said at the outset, we know things are very busy and hectic up there in Wisconsin. So thank you so much for taking some time with us, and please stay safe.
I appreciate that. Thank you very much.
Thanks. And I'm Matthew Weinstock with Modern Healthcare. Be sure to tune in next Monday for another edition of The Checkup.